Okay, moving to the next section, cellular injury. Probably the easiest way to understand this section is to put it in the context of what we just covered. So you'll recall that I said that a cell can be stressed, and that stress can lead to growth adaptations. In particular, if there's an increase in stress, we would expect to see hyperplasia and hypertrophy. If there was a decrease in stress, we would expect to see atrophy. And if there is a change in stress, we would expect to see metaplasia. Now, it is possible that the stress could be so severe that it exceeds the cell's ability to adapt. Exceeds the cell's ability to adapt. Now, why is that important? Because if the stress exceeds the cell's ability to adapt, then rather than undergo a growth alteration or a growth adaptation, the cell will actually become injured. And that's really what this section is all about, cell injury. Now, we could ask a simple question here. What determines whether the cells of an organ are going to adapt or they're going to become injured? Well, actually, there's three major factors. The first is the type of stress. So, for example, if a cell were to, or if an organ were to become inflamed, it's much more likely that the inflammation would result in a growth adaptation than perhaps injury. The severity of the stress is also important. Just to give you a very simple example, if you slowly cut the blood supply to the kidney will atrophy due to the decrease in nutrients. So maybe a classic example of that would be atherosclerosis of the renal artery or fibromuscular dysplasia of the renal artery. Either of these two pathologic processes would slowly cut the blood supply to the kidney, and as a result, the kidney would shrink in size because it would undergo atrophy. So that's slowly developing ischemia, or a slow cutting off of the blood supply. However, if there was a thrombus in the let's say, for example, left heart, and that thrombus was to break off and embolize and then lodge into the renal artery, that could block the blood supply to such an extent that a cutoff of the blood supply to, let's say, completely would actually result in infarction or death of the kidney parenchyma. And so here we see that sort of the same theme in the sense that we cut the blood supply in the renal artery, but a slow, progressive cutting blood supply of the renal artery would result in atrophy of the kidney, whereas a rapid, complete cutting off of the blood supply of the renal artery would result in infarction and injury of the cells. So that would be an example of the severity determining what happens in response to a stress. And the third factor that determines what happens in response to a stress is the type of cell that is affected. Now, what do we mean by that? Well, one of the high-yield principles to be familiar with, and examiners like to go after this, is the fact that neurons are very susceptible to hypoxia. In fact, the neuron has the ability to withstand hypoxia for only 3 to 5 minutes, whereas skeletal muscle, which is another type of cell, actually can withstand hypoxia for very long periods of time. And so the type of cell affected will also determine how the organ or the cell adapts to a particular stress. Anyway, in this particular section, we're dealing with injury. And so if I just very quickly read to you what we have here on our text, we say that injury occurs when the stress exceeds the cell's ability to adapt, as I've already explained. And the likelihood of injury is going to be based on the type of stress, the severity, and the type of cell that is affected. All right, so moving on, while we're on this topic of cellular injury, we should remind ourselves that as we go through the remainder of this text, there are going to be many common causes of injury. For example, inflammation is a common cause of injury. You can take any example. If a patient gets an infection, a pneumonia, that's going to injure the lung. At the same time, there are some chronic inflammatory states like autoimmune diseases that would also result in injury. Nutritional excess or deficiency can result in injury. We're all familiar with that. In fact, much of the disease that we see in the Western world is actually due to nutritional excess. And much of the disease that we see in areas where poverty is prevalent is really due to nutritional deficiency. So these are common causes of injury as well. Hypoxia, very classic cause of injury. All of the myocardial infarctions and stroke, ischemic stroke to the brain are all examples of hypoxia. And we're actually going to spend some time discussing hypoxia in more detail in a few minutes. Trauma, common cause of injury. For example, a gunshot wound to tissue will injure the cells. And genetic mutations. When there are mutations and proteins are not formed or not formed properly, that can also result in cellular injury. Now, all of these themes are going to be repeated as we go through the text. However, what I want to really focus on for the next few minutes is hypoxia. Hypoxia is a nice model for studying cellular injury, and so we're going to focus on that over the next few minutes. So before we can begin our discussion of hypoxia, we really need to understand the term hypoxia. So let's do it this way. Hypo means low, and oxia refers to oxygen. And so hypoxia is low oxygen, and in particular, it's low oxygen delivery to tissues. Now recall that tissues are essentially dependent on oxygen. And the reason they're dependent on oxygen is because oxygen is the final electron acceptor in the electron transport chain. That accepting of electrons by oxygen allows for the generation of ATP, and so low oxygen is going to impair oxidative phosphorylation, leading to low ATP. And low ATP, which is an essential energy source, will lead to injury. So why don't we just summarize it by saying low oxygen, low ATP, cellular injury. And that's why hypoxia causes cellular injury. Okay, so the next discussion would be what are the causes of hypoxia? And actually there are broadly speaking, there are three major causes of hypoxia. The first is ischemia, the second is hypoxemia, and the third is a decreased O2 carrying capacity of the blood. We'll actually elaborate on each of these in the next few slides. So let's start with ischemia. Ischemia is decreased blood flow through an organ. Probably the easiest way to think about this is, I'll draw you an image here. This is the artery, and it is feeding any organ. It doesn't matter for this particular discussion. And this is the vein, which is draining that organ. Now, ischemia refers to decreased blood flow through that organ. So this is the way that blood would be flowing through the organ, obviously. And ischemia can occur in two ways. The first way, well, actually there's three ways, but two very common ways. The first way would be for there to be a block in the arterial flow into the organ. So if there's a block in the arterial flow, for example, atherosclerosis, that would decrease the blood flow going through the organ, which would then result in ischemia within this organ. I think we're all very familiar with that. It's a common principle in pathology. It's going to result in many disease processes. For example, when there's atherosclerosis of the coronary artery, that results in angina or episodic chest pain. But we don't need to worry about those details yet. We'll get those later. The idea here is that decreased atherosclerosis of the artery would result in decreased blood flow through that organ. I think we all have that down. The next, the other way by which we could get ischemia, and perhaps this is something that we don't think about as much but shows up often on examinations, is that we could decrease the flow through the vein. And if we block this vein, for example, then we would block the flow of blood across this bed, and by blocking the flow of fresh blood across that bed, we would decrease the amount of oxygen within this organ. And that would then result in ischemia of the organ. Now, there are many examples in pathology of this, but there's one very high yield, shows up on examinations all the time, and that is a syndrome called Budd-Chiari syndrome. Budd-Chiari syndrome we'll actually discuss in more detail when we cover liver, but in Budd-Chiari syndrome, there's a thrombosis of the hepatic vein, and by blocking the hepatic vein, blood no longer can flow through the liver, and that results in infarction within the liver parenchyma. It can actually cause death. That's Budd-Chiari syndrome, very high yield. Another high yield derivative of Budd-Chiari syndrome, as long as we're on that topic, I can ask you the question, what's the most common cause of Budd-Chiari syndrome? So the answer in your mind should be that the most common cause of Budd-Chiari syndrome is polycythemia vera. Recall that polycythemia vera is actually a disorder in which patients have a high red blood cell count due to overproduction of red blood cells, and that makes the blood thick and viscous. And the increased thickness and viscosity of the blood leads to a complication of thrombosis or clotting. And one place in which thrombosis can occur is within the hepatic vein, which would then lead to Budd-Chiari syndrome. Just as long as we're on the topic, another classic example of Budd-Chiari syndrome or cause of Budd-Chiari syndrome would be a patient with lupus who has something called lupus anticoagulant, which creates a hypercoagulable state in that patient. So anyway, I don't want to press too hard on the specific examples, but really at this point I'm trying to lay down a basic principle in your mind. We'll really have a lot of time to talk about the common and classic examples of Budd-Chiari when we do the liver. So this is one way by which ischemia can occur, and of course ischemia would be a cause of hypoxia, which is the discussion that we're having. A third way by which ischemia can occur is called shock. Shock refers to a generalized decreased perfusion of the vital organs, and it can occur, for example, if the heart's not functioning properly, we get a cardiogenic shock. If there's not good blood volume in the vascular space, because let's say there's a gunshot wound, we'll have a hypovolemic shock. There's also a neurogenic shock, an anaphylactic shock, a septic shock. In each of these cases, the central theme is that there's a decreased ability to perfuse the vital organs. And of course, if blood is not flowing to the vital organs, that would be an example of ischemia, and that would result in hypoxia of the cells, or decreased oxygen going to the cells. The second cause of hypoxia is hypoxemia. Now, here, we've got that same hypo and then oxygen, low oxygen, but emia means in the blood. And so hypoxemia refers to a low pressure of oxygen, or low partial pressure of oxygen within the blood. Very specifically, it would be defined as a P small aO2 less than 60 millimeters of mercury, and that would translate usually to roughly an SaO2 of less than 90%. This sometimes confuses students, the concept of hypoxemia, and so I think that maybe we should take a step back and review a little physiology here in order to understand this concept a little better. So why don't we do it in the following way? Let's remember that there's a certain concentration of oxygen present within the atmosphere, which is called the FiO2. This is really the fractional percentage of oxygen within the atmosphere. And the goal of the lungs is to bring that FiO2 into the alveolar air sacs and to create something called the P big aO2. So the P big aO2 is a partial pressure of oxygen within the alveolar airspace. Now that PaO2 squeezes oxygen. That pressure is used to squeeze oxygen across the interstitium and into the capillaries, which then creates a P small aO2, which is the partial pressure of oxygen within the arterioles. And then that PaO2, that P small aO2, its goal is to squeeze oxygen across the red blood cell membrane to load oxygen onto hemoglobin, creating an SaO2. So this is sort of the sequence of how oxygen is squeezed eventually into hemoglobin. So the FiO2 results in a PaO2, big aO2, which is the pressure of oxygen within the alveolar airspace. That squeezes blood across the barrier that squeezes oxygen across the barrier into the blood, which creates a P small aO2 in the arterioles. And then that squeezes oxygen across the cell membrane, the red blood cell membrane, into the red blood cells, which then creates an SaO2. Now, hypoxemia, again, as I've already told you, refers to a low PaO2. So really, this number would be low. But you can see that what actually feeds the P small aO2 is the FiO2 and the P big aO2. So any change prior to this, in this sequence, in the early phases of this sequence, would also decrease the PaO2. So let's just take some common examples. If a patient is at high altitude, all right, high altitude, then when they're at high altitude, the FiO2 is actually decreased. Well, the partial pressure overall of oxygen in the air is the overall pressure is decreased, the atmospheric pressure is decreased, and therefore the oxygen pressure is decreased at high altitude. So at high altitude, the FiO2 would go down, which would decrease the P big AO2, which would decrease the P small AO2, which would then result in a state called hypoxemia. So that's one example. Another example would be to decrease the P big AO2. The classic way by which the P big AO2 decreases is anything that increases the P big A CO2. The P big A CO2 would actually decrease the PaO2, and that's because recall that there's a certain pressure that can exist, and it's a balance between oxygen, carbon dioxide, and nitrogen is a constant. So anytime the P big A CO2 goes up, anytime there's carbon dioxide building up in the lung, the PaO2 will always go down. They're always opposite. So what would be some examples where carbon dioxide would build up in the lung, which would then knock down the P big AO2? Hypoventilation, where carbon dioxide gets a chance to pile up in the lung because it's not being blown off. That's one example. Another example, which would cause this, would be COPD. In COPD, you're very, very familiar with the fact that air gets trapped within the lung, chronic obstructive pulmonary disease. Air is being trapped within the lung, and so that would also decrease the P big AO2. Now, once the P big AO2 goes down, then automatically the P small AO2 is also going to go down, and that's obviously going to be hypoxemia. Another way by which hypoxemia can occur, remember that the P big AO2, its goal is to squeeze blood into the capillaries of the alveolar air sac. So let's say that we thickened the alveolar air sac so that this pressure, the P big AO2, would not be able to squeeze as much blood into the capillaries. An example of that would be interstitial fibrosis of the lung. When there's interstitial fibrosis of the lung, the oxygen diffusion barrier increases or thickens, and therefore oxygen can't be squeezed very well into the blood. So that would be another example of how hypoxemia might occur. So again, I think if you understand the general idea here, it gives you a very good grasp on what we mean by hypoxemia. Now, obviously, anytime the P small AO2 here goes down, that's also going to decrease the SaO2, because this is the pressure that actually was creating the SaO2. And you can review your oxygen dissociation curves, and you'll see that to be true as well if you were to correlate these numbers on the oxygen dissociation curve. So I hope that clarifies the concept of hypoxemia. But the general principle that I'm really trying to get at here, aside from the physiology that I just mentioned, is hypoxemia refers to a low partial pressure of oxygen within the blood, and it's another cause of hypoxia, which is, again, the broad topic that we're talking about. A third way by which we could create hypoxia, or by which hypoxia occurs, is to have a decreased O2 carrying capacity within the blood. Now, in order to understand this, remember that the dissolved oxygen within the blood actually enters the red blood cell and then binds hemoglobin. And it's hemoglobin that actually has the role of carrying oxygen to the tissues and eventually unloading it at the level of the tissues. Recall from physiology that the vast majority of the oxygen content of the blood is actually due to oxygen bound to hemoglobin. And so if you knock out the red blood cells, or if you knock out the ability of the red blood cell hemoglobin to carry oxygen, that will also result in hypoxia within a tissue. Let's just give you a few examples of that to highlight this idea, and because this one of the few places we'll get to discuss this principle. One example of a decreased O2 carrying capacity of the blood would be anemia. Remember that anemia refers to a decrease in the total red blood cell mass in the body. And when there's a decrease in red blood cell mass, there's going to be a decrease in the amount of oxygen being carried in the blood. And therefore, if there's a decrease in the amount of oxygen being carried in the blood, there's obviously going to be a decrease in the amount of oxygen going to the tissues, i.e. hypoxia. And so one important thing to remember is that if we go back to our paradigm that we had just established, if you have an FiO2 and the FiO2 is generating a P big A O2, and that's generating a P small a O2, and that's eventually going to generate an SaO2. What we should remember is that when we have anemia, there's no problem with the the atmospheric oxygen. There's no problem with the ability to bring oxygen into the lung. There's no problem with the ability to squeeze oxygen into the blood. So the PaO2 is actually normal. At the same time, the SaO2 is normal as well. And the reason the SaO2 is normal is because hemoglobin, the SaO2 just looks at what percentage of the hemoglobin is bound by oxygen. And so if you have, if you've got, I don't know, let's just pretend that I've got 3 red blood cells in my entire body, and each red blood cell is carrying 4 molecules of oxygen. In that case, I'm 100% bound because each cell has the ability to carry 4, and each cell is actually carrying 4. Now, if I get an anemia, let's say that I get an anemia and I knock out 1/3 of my red blood cells, each of my remaining blood cells is still carrying 4 molecules of oxygen. And so here I'm again 100% bound and 100% bound. So the SaO2 does not, because it looks at the percentage of the percentage of oxygen molecules that are bound to hemoglobin, it's not going to be altered in an anemia. So I hope that's clear. Another way by which we can have a decreased O2 carrying capacity of the blood is carbon monoxide poisoning. And this is a very high yield topic for examinations. And so let's briefly review this. The idea here is that carbon monoxide is a very avid binder of hemoglobin. It binds hemoglobin 100 times more with a 100 times affinity as opposed compared to oxygen. Now, carbon monoxide is actually an odorless, colorless gas, and it can sneak into the lungs, and then it can bind the hemoglobin, and once it binds the hemoglobin, it doesn't let the hemoglobin go, and therefore oxygen can't bind. Now, in this particular case, the PaO2 will be normal. Again, there's no problem with the FiO2, there's no problem with the Pa big O2, and there's no problem with the P small aO2. And so therefore the PaO2 will not be changed. It will be normal. However, the SaO2 will be decreased. And the idea here is that if you've got a red blood cell and it normally has the ability to hold 4 hemoglobin molecules, but let's say it can only hold 2 because of the fact that the other 2 spaces are bound by carbon monoxide, that's going to be a reduction in the percentage of spaces that are bound by oxygen, and so the SaO2 will actually be decreased. Now, important to recognize for examination purposes and for clinical purposes, the common exposures that lead to carbon monoxide poisoning include smoke from fires. So any patient that happens to be, let's say, exposed to smoke from a house fire or some fire of that nature can develop carbon monoxide poisoning. Another important source of carbon monoxide poisoning would be exhaust from cars, and this is the classic example of a patient who might try to commit suicide by carbon monoxide poisoning, where they start their car and they shut the garage door and the carbon monoxide slowly builds up within that closed space. And then a third way by which carbon monoxide poisoning can occur is via gas heaters, and that's a relatively high yield sort of clinical scenario that can show up on exams. The classic finding in a patient with carbon monoxide poisoning is the cherry red appearance of the skin. The reason the skin looks cherry red is because the hemoglobin is so tightly bound that it creates reflects the red light and allows and creates this red appearance to the skin. However, it's deceptive because the patient actually is actually hypoxic because they aren't carrying oxygen to their tissues. So although they look very red, they're not getting good oxygen delivery to the tissues. Now, another important point here, and it's kind of high yield, is when you look at most textbooks, they'll actually list the various things that occur in stages as carbon monoxide poisoning occurs. For example, the earliest change is headache, and then the patients can get confusion, etc., until eventually it leads to coma and death. Now, the leading of carbon monoxide poisoning to coma and death shouldn't be difficult for you to remember because, as I told you, it's a mechanism by which patients commit suicide, or an individual could commit suicide. And so I don't think that's hard to remember. But what is very important to remember, especially for examination purposes, is the fact that the early sign of exposure is headache. And I guess this would also be important clinically, because if you've got a patient that has been exposed to a fire or comes in after some type of exposure and you want to screen, just a very quick clinical history screen, you can ask the patient, do you have a headache? Or if the patient complains of a headache, you really want to then sort of raise carbon monoxide, the worry for carbon monoxide poisoning, especially with an exposure. So for examination purposes, I would say very important to remember that an early sign of exposure is headache. A third way by which we could decrease the O2 carrying capacity of the blood is called methemoglobinemia. The idea here goes back to a little bit of biochemistry, so this is why it becomes high yield. Again, examiners love to take biochemical principles and when they apply to clinical scenarios, it's a great way to test. So these things become very high yield. You don't really see methemoglobinemia very commonly except on examinations. So the idea here is that remember that the heme in hemoglobin actually contains iron. And that iron is normally in an Fe2 plus state. Now the Fe2 plus is what binds O2. And I usually tell my students that this is very easy to remember. Fe2 binds O2. Fe2 binds O2. So if the Fe becomes oxidized and goes into a 3 plus state, then Fe3 plus is not able to bind O2. So if the iron in the hemoglobin becomes Fe3 plus, that is called methemoglobinemia, and the hemoglobin is no longer able to appropriately carry oxygen. Now in this particular case, the PaO2 would be normal, and we've already covered this. There's no change in the FiO2. There is no change in the P big AO2. The lung is able to fill and gather oxygen and blow off carbon dioxide appropriately. And so therefore the PaO2 in the blood, the partial pressure of oxygen within the blood, would be normal. The SaO2, however, is decreased because if you've got a red blood cell, and the red blood cell again is only able to carry, for example, 2 molecules of oxygen instead of the normal 4, that would be a 50% saturation, and so the SaO2 would be decreased. Now, the next point to be aware of in this context is in what clinical context would we actually see methemoglobinemia? And classically, it's seen with oxidant stresses. Oxidant stresses would actually have the ability to oxidize the iron. So what are some oxidant stresses? Well, sulfa drugs are oxidant stresses. Nitrate drugs are oxidant stresses. Those are the classic ones, and those are the way by which they tie in a little bit of pharmacology on examinations. Another group of patients that can actually develop methemoglobinemia are newborns. Now, in order to understand that, you should probably go back and remind yourselves that we're always oxidizing iron within hemoglobin, and all of us within our blood probably have a very tiny percentage of methemoglobin floating around in the blood. And that's because the blood carries oxygen, and there's an oxidizing stress there's an oxidant stress that's constantly present within blood. And so physiologically, we actually have enzymes that participate in creating the mediators necessary to reduce oxygen back to its 2 plus state. Reduce iron back to its 2 plus state. Now, newborns, their machinery to be able to do this is a little bit immature. And so newborns are particularly susceptible to the development of methemoglobinemia. The classic clinical finding in methemoglobinemia is chocolate-colored blood. Chocolate-colored blood. And the patients will be cyanotic. So they often, sort of the buzz phrases are cyanosis with chocolate-colored blood. Chocolate-colored blood. Now, the treatment is IV methylene blue, and what does IV methylene blue do? It's important for being able to generate the necessary mediators that will reduce iron back to its 2 plus state, and I've stated that here by saying that it helps reduce iron back to its 2 plus state. So if I were to say if I wanted to summarize methemoglobinemia in just a very simple principle, I would say just remember Fe2 binds O2. and that's going to make it very easy to remember. Okay, now we get to the general theme of what are the consequences of hypoxia. So we talked about 3 different ways by which hypoxia can occur. For example, we talked about ischemia causing hypoxia. We talked about hypoxemia resulting in hypoxia. And then we talked about decreased O2 carrying capacity resulting in hypoxia. So when we have hypoxia or low oxygen delivery to the tissues, what's the consequence? That's sort of the next discussion. And the key consequence is that it impairs oxidative phosphorylation. I've already told you prior, and we can repeat this here, oxygen is necessary as the final electron acceptor in the electron transport chain. And low oxygen will result in low ability to generate ATP, and low ability to generate ATP will result in cell injury because ATP is a necessary energy source for cells. So the key principle here is that hypoxia impairs oxidative phosphorylation, which decreases ATP. Now, what's the problem with having a low ATP, and why does that cause cellular injury? It's particularly when it's severe. Well, the idea here is that ATP is necessary for key cellular functions, and perhaps the most important and highest yield would be the notion that ATP is necessary for the sodium-potassium pump. Now, let's go back and remind ourselves that cells have a sodium-potassium pump, and the goal of that pump is to push sodium outside of the cell. If the pump fails, in particular here, due to a lack of ATP, then sodium will build up within the cell. And if sodium builds up within the cell, guess who's going to follow? Yes, water. Water will follow, and when water follows, the cell will actually swell. And the swelling of the cell can result in damage, is a sign of damage to the cell. So this is one important function that gets disrupted, and I would say it's one of the very important functions, as you'll see in a moment when we discuss the next slide. The second function that gets disrupted is the calcium pump. Now, let me just tell you one general principle about calcium in the cell, and that is the goal of the cell is to maintain a super low concentration of calcium within the cytosol. The calcium in the cytosol is very, very low. The calcium can get pushed out into the blood, it can get hidden in the mitochondria, it can get hidden in the endoplasmic reticulum, but within the cytosol itself, calcium concentration is kept very low, and it's done using ATP, using an ATP-dependent pump. And so if there's low ATP, the calcium pumps can fail, and that would result in a high cytosolic calcium. And the high cytosolic calcium is dangerous because it can activate enzymes which you wouldn't necessarily want to activate within the cell. So calcium is an enzyme activator. The third disruption that occurs with low ATP is that we switch from aerobic glycolysis, which is very good at producing ATP, to anaerobic glycolysis, which then results in the byproduct of, number one, the poor production of ATP, and number two, the production of lactic acid, which lactic acid would lower the pH within the cell, and the lowering of the pH would cause precipitation of both DNA and proteins. And so this would be another problem that would arise when we have low ATP within the cell. The very initial phase of injury that occurs when there's low ATP is reversible. And so examiners like you to know what are the various findings in reversible injury, and what are the various findings if we were to go a step further and have irreversible injury. Very, very high yield, often shows up on exams. So let's take a moment to actually review this. The initial phase of injury, as I state here, is reversible. And what I'd like you to know is that if you had to summarize reversible injury in 2 words, you would summarize it as cellular swelling. This is the hallmark of reversible injury. Now, let's just understand that. Again, if the sodium-potassium pump fails, then sodium will build up within the cell, and as sodium builds up within the cell, water is going to follow, which is then going to result in swelling of the actual cell. Now, this would have consequences for various parts of the cell. For example, let's say that I have a cell that looks like this, which has these little processes coming off the surface called microvilli. Remember that microvilli are present, for example, in the small bowel, and present, for example, in the proximal renal tubule. And the purpose of these microvilli is to increase the surface area of the cell so that you could better absorb products. For example, in the proximal renal tubule, you want to absorb the things that you want to bring back into the blood from the filtrate of the glomerulus. In the small bowel, you want to be able to absorb all of the food that's being digested along the brush border or the edge of the cells of the enterocytes of the small bowel. So the idea here, again, is that normally some cells in the body have microvilli. However, if these cells become hypoxic and lose their oxygen and then subsequently can't produce ATP, sodium is going to build up in these cells, and as sodium builds up, water is going to come in, and as water comes in, these microvilli are going to be, the cell is going to swell up, and these microvilli are going to be effaced or lost so that the microvilli are no longer present. It's sort of like taking a hospital glove or a medical examiner's glove and blowing it up, and the fingers will disappear as you put more air into the glove. So as you put more water into the cell, these fingers on the surface of the cell are going to disappear. So that's why one of the hallmarks of reversible injury is loss of microvilli. So most textbooks will tell you, and examinations will ask you, about the loss of microvilli. Another important feature of reversible injury, it again goes back to cellular swelling, is membrane blebbing. So let's go back and remind ourselves that if this is the cell contains something called a cytoskeleton, and the cytoskeleton maintains the size and shape of the cell, but also maintains the integrity of the membrane along the surface of the cell. Now, if there is excess water coming into the cell, then little blebs can form on the surface of the membrane as they sort of pull away from the cytoskeleton, and that would be another sign of reversible injury. But again, what's the key principle? Cellular swelling. So that's the hallmark. That's why I say that if you just understand cellular swelling, everything else is sort of a consequence of that. All right, the third problem that could arise in reversible injury is swelling of the rough endoplasmic reticulum. Now, I mean, if we've got a cell, and within that cell we've sort of got this endoplasmic reticulum, and this is rough endoplasmic reticulum with ribosomes sitting along the edge, that organelle itself, the endoplasmic reticulum, is going to fill up with water, and it will swell. And when it swells, that will also be a sign of reversible injury. Now, let's go back and just remind ourselves. The ribosomes that are attached to the endoplasmic reticulum, are those attached covalently, or is it a loose association? It's a loose association. And so because it's a loose association, one of the consequences of swelling of the rough endoplasmic reticulum is that these ribosomes will actually pop off. And so when these ribosomes pop off, protein can no longer be synthesized properly, and therefore another sign of reversible injury is decrease in protein synthesis. So again, I don't think, again, I don't like to memorize long lists of things. I think if you understand the principle, then you can really put together the story. And that's the way I would put together the story here. The key hallmark of reversible injury is cellular swelling. That's the take home. Now, eventually, if there's damage and the damage it persists for a long period of time, if there's injury and that injury persists for a long period of time, that damage will eventually become irreversible. Now, if I would tell you that reversible injury is summarized by cellular swelling, then I would tell you that irreversible injury is summarized by something called membrane damage. That's the take home. The hallmark of irreversible injury is membrane damage. We could take this one step further, and we will take it one step further because it does show up on exams. There are three membranes of the cell in particular that get damaged and result in the key consequences of irreversible damage. The first is very obvious, and in fact, it's so obvious that it makes for, we use it sort of every day, and you'll see that in a minute, but it makes for a nice exam question. So let's just remind ourselves that one important membrane within the cell is the plasma membrane, which is the membrane that sort of borders the entire cell. When there is irreversible damage, this plasma membrane will be damaged and will be lost. And as the plasma membrane is lost, whatever is present within the cell, for example, let's say there's an enzyme present within the cell, this enzyme will leak out of the cell and into the blood, and then will result in that will be then a sign of the membrane damage. What I'm really trying to get at here, and the reason I'm pressing on this so hard is, think about it this way. When you have a patient that comes into the ER, let's say you're the ER physician and the patient comes into the ER, if they're complaining of chest pain and you're worried about a myocardial infarction, one of the key sort of gold standard tests, the first test would be an EKG. That would really show changes, particular changes that would be important. But another very important test would be to simply stick a needle in the patient's vein and take blood and then send it to the lab and test for cardiac enzymes. Now, when you test for cardiac enzymes like troponin, what are you really asking? What's the question that you're trying to answer by testing for those enzymes? You're asking the following. You're asking, was there irreversible damage? Because myocardial infarction means that you have irreversibly killed off the myocytes. And so you're asking the question, have the cardiac enzymes gone from the cell into the blood? And if they have gone from the cell into the blood, for example, troponin, then you would say, aha, there is myocardial infarction, and myocardial infarction is basically irreversible damage. So this becomes a very high-yield principle because you test it all the time. When you're asking the question, if you're asking the question, does the patient have hepatitis, and you're actually measuring liver enzymes, you're really asking the question, has membrane damage occurred? And i.e., if membrane damage has occurred, then there must be irreversible damage going on within the liver. So I hope that makes sense. Another problem, or another consequence of loss of the plasma membrane, is that the calcium, which is present outside of the cell, so much effort was made to keep calcium outside of the cell. As I mentioned earlier, the calcium now can rush in as well. So the intracellular calcium levels will increase even further. So these are the two consequences of plasma membrane damage. Another membrane that is going to be damaged is the mitochondrial membrane. Now let's go back. So this is going to be a cell here, and we know that within the cell there is a mitochondria. I can just draw it like that. This is pretend that's the mitochondria. And so within the mitochondrial membrane is important because for two reasons. Let's remind ourselves about one thing. First of all, let's ask a question, and it commonly shows up on exams. Where is the electron transport chain? The electron transport chain is on the inner mitochondrial membrane. That's something to burn in your brain. Inner mitochondrial membrane. And so if there is membrane damage to the inner mitochondrial membrane, that's going to be permanent. That's irreversible. Because even if you were to give the cells oxygen, return oxygen to the cells, those cells would never be able to recover from that damage. So that's irreversible damage. It cannot be reversed, even if oxygen is returned to the tissue. So that's one consequence of damaging the mitochondrial membrane. Another high-yield consequence of damaging the mitochondrial membrane is that within the mitochondria there is a very important molecule called cytochrome C. So cytochrome C. Now, cytochrome C is present within the mitochondria and is actually kept it's carefully guarded. Why don't we put it that way? If cytochrome C leaks out of the mitochondria and comes into the cytoplasm, it has the ability to activate apoptosis. And apoptosis is a mechanism of cell death. So another consequence of damaging of the mitochondrial membrane is that cytochrome C can now leak out from the mitochondria into the cytosol. And when it leaks out into the cytosol, it will activate apoptosis, causing cell death. So that's another consequence of mitochondrial damage. A third type of membrane that is damaged is the lysosome. Now let's go back and remind ourselves that if this is a cell, one of the organelles within the cell is a lysosome. The lysosome is sort of the recycling factory of the cell. It contains lytic enzymes that have the ability to trash molecules into their basic building blocks. Now imagine if the enzymes present within the lysosome actually leak out into the cytosol, those enzymes are going to start trashing the cell itself. It's going to basically digest the cell. So that would be one problem. And that's only further added to by the fact that that calcium has already come into the cell, and calcium is an enzyme activator. So the presence of calcium and lysosomal enzymes within the cytosol becomes a very, very dangerous circumstance, which obviously would be another consequence of irreversible damage. So again, these are the high yields, and I don't memorize these things. I'm really actually just sitting here talking off the top of my head. I don't have any notes in front of me. And the reason I can talk off the top of my head is because it makes sense. If you just remember membrane damage being the source, being the key hallmark of irreversible injury. Okay, the end result of irreversible injury is cell death. And cell death is a separate topic. We'll discuss that in more detail in the next section. Why don't we stop here, and then we'll continue on with cell death.